Awesome. Well, I think we'll just get started. Hopefully more people hop on. Hi, everyone. My name is Sarah Sweet Murga. Welcome to our community of practice. For those who haven't attended, we are MultiNet, which stands for the Multicultural Disability Network. We gather monthly, around monthly, to discuss topics relevant to individuals with disabilities and multicultural communities. So today we're really happy to have Rachel here with us to talk more about health equity. But in addition to these meetings, I also oversee our monthly newsletter and coordinate upcoming webinars. But I will hand it over to the rest of my team to do their introductions.
And I can start. I'm the other Sarah on this project, and I am the staff assistant, so I help schedule meetings and schedule these events as well as all the marketing, email marketing for them. So just try to help it run smooth.
And I'm Mindy Dokis. I work on this project, handling a lot of our online media as far as our social media. I'm live. I'll be live tweeting this meeting. So if anybody's on Twitter/X now and wants to join us, please join us there. Instagram, Facebook, LinkedIn, also YouTube. And I also create our infographics and digital storytelling episodes, which are interviews with people with lived experience that are all posted on our website. So I'm gonna share in the chat our links to all of that. So if you're interested and want to join us there, watch for that. Thanks.
Awesome. Thank you, guys. Before I pass the time over to Rachel, does anyone have any questions about the MultiNet project? Okay, awesome. Well, Rachel, the time is yours now.
Well, thanks so much for having me here today. I'm really excited. These are a couple of my favorite topics. So when you asked if I'd be willing to come and present and lead some discussion, I was very happy to do so. If you guys have never been to a community of practice before, this is different than a traditional webinar or training where there's a lot of information thrown at you within an hour. Community of practice meetings focus more on interaction and discussion. So there will be a few points here throughout my slides where we have group discussion, learn a little bit about who we have here and what professions are represented and what some of these topics mean for us in our work. Specifically today, we're going to talk about health equity and intersectionality, and I'll dive into a little bit about why these are important to me. Every time I present, I like to give a little bit of background about who I am and why I do what I do, which is always a little bit of a tongue twister for me. There are so many W words in there. But I have a background in residential habilitation or disability services. I managed residential habilitation services in Idaho for a little while. That was my introduction to working with people with disabilities beyond volunteering with children with disabilities. This was really the first time that I was fully hands-on, seeing what disability services are like in real time, and having the opportunity to work as a direct support professional. I often filled in for shifts when staff were unavailable. It was a really eye-opening experience. For me, I learned very much about health disparities in that role. It was so eye-opening to see how difficult it was at times to access healthcare and how participants often left healthcare appointments feeling like their needs weren't met. It's very complicated to access healthcare in our system as someone with a disability. I'm also a mental health advocate. Personally, I have anxiety. I also have obsessive compulsive disorder or OCD. I am very passionate about promoting access to mental health services and also promoting mental health literacy. So I do provide mental health literacy trainings. That's something that I do with our team here. I'm also very much passionate about health education and prevention. So after working in disability services, I knew I wanted to continue along the public health path. I got my master's of public health from Idaho State University. I'm also a certified health education specialist. So I do some research here at the Institute for Disability Research Policy and Practice. I am also a doctoral student, and my focus is really on health outcomes for people with disabilities My projects right now are very specific to mental health outcomes for people with intellectual and developmental disabilities specifically. I'm also on a subcontract with the Department of Health and Human Services, where we provide training and technical assistance to some rural counties and health departments about health equity, particularly focusing on individuals from diverse backgrounds who also have disabilities. That's a little bit about me. In a community of practice, discussion is very important. It's good to know who we have here and what backgrounds are represented. So I've talked a bit about me. I am from public health, and I'm currently working in a very disability specific field. So when I talk about health equity and intersectionality, I have a very large focus on disability and the role that plays in equity. I'd love to know everyone that we have here. You can shout it out, feel free to unmute, or you can add in the chat a little bit about what you do or what your background is and why you do what you do.
I can share if that's okay.
Yeah,
So I'm Trevor Carter. I'm from Central Utah Health Department as the Director of Community Health. So I oversee our health promotion, emergency preparedness, and health equity work within Central Utah within the 6 counties. And I love public health. I love being able to make a difference. And one of my coworkers is on the call, Monica Hernandez. She is our health equity coordinator. And I love that we really get to make a difference in our community. And our counties are rural and frontier. So we are actually starting from ground zero, I feel like. And it's awesome because we've made great progress. And Monica's done a really good job of getting our county commissioners, our Board of Health on board and understanding what health equity is. And they see it not as a political issue, but they see it as including all people in healthcare.
awesome. Thanks for sharing, Trevor.
I'll just introduce myself again if that's okay, Rachel. Okay, cool. So as I mentioned before, I'm Sarah. So I'm the project coordinator for the MoldyNet project. I don't remember if I mentioned that when I started talking about it at the beginning. But the reason why I enjoy being a part of this is just being able to learn and understand more about the different communities, different cultures. It's just very eye-opening and also just very a very rewarding job. And like this knowledge is just invaluable, not just to me, but for everyone, I feel like. And so it's really nice to be able to take a part in a community and a project where it focuses on outreaching to others and giving them that information so that they can feel the same way.
Awesome. Thanks, Sarah. Bonnie or Lane, would either of you like to share a little bit about what you do and why you do what you do?
Sure. My name is Bonnie, and I work at the Utah County Health Department. I'm a health educator there. We've done some, we got a special grant to focus on disability during COVID with our vaccination clinic. So I helped with that for a couple of years. And now we have a small grant that focuses on individuals with disabilities, just like a $10,000 grant. And so I'm working on that.
Awesome. Thanks, Bonnie.
My name's Lane Coyle. I am a prevention specialist. I actually am employed through Tooele County Health Department, but I also work in mental health prevention through the Northern Utah Hope Task Force based out of Weber State University. And I used to work in early intervention up at it used to be the Center for Persons with Disabilities, but now it's, I forget the name, the Institute for Disability Research, Policy and Practice, that long name.
Yeah.
So,
It's
so yeah, I'm very passionate about the programs that you guys have to offer and excited to learn more about this topic.
well, cool. Glad to have you here, Lane. And I will say, I do recognize Breck and Teresa. They are actually the ones that I work with on my Utah Department of Health and Human Services subcontract. So we interface frequently. They're with the Office of Health Equity, and they do a lot of really important work. Monica, feel free to share if you'd like, but we do know that you work with Trevor.
Hi. Yeah, I think Trevor covered it really well. I just am excited to hear what everyone else is doing today and to hear from you. So thank you.
Awesome. Thank you, everybody. We're going to jump right in and look at what the textbook, my air quotes, definitions of health equity and intersectionality are. So these ones are, there are multiple definitions. They're very similar depending on where you look. I've pulled specifically from the CDC for the health equity definition, which is the state in which everyone has a fair and just opportunity to attain their highest level of health. And the Cambridge Dictionary is what I used for intersectionality, which is the way in which different types of discrimination are connected to and affect each other. The reason that I pull up these official definitions is because our understanding of these terms are informed in a lot of ways. And I don't think it's inaccurate to say that a lot of people have never looked up the official definition of health equity or intersectionality. I think a lot of our opinions are based on what we hear. I believe it was Trevor who mentioned that some of these terms are very political, and a lot of people's opinions are influenced by what they hear through political channels. So I like to start out with this. Clean slate is not the right word, but our official definitions are here from the CDC and the Cambridge Dictionary. Now, there is an important acknowledgement in that just because they're defined officially in one way doesn't necessarily mean that that is how we use them in practice, or it doesn't necessarily capture the entire definition and how important they are and the role that they play in our practice. So the next step there is to discuss what these definitions look like in practice. So how are health equity and intersectionality involved in your work? I will start. So I do have a very passionate background in public health. I do a lot of reading and have done a lot of reading about health equity, inequities and inequalities that are faced by people from different groups. And the projects that I do focus on identifying what those health disparities are and hopefully eventually finding ways to decrease those health disparities. Some things that I do are more exploratory. I had a project earlier this year where, well, last year now, because it's 2024, where I used photo voice, which is a qualitative method to explore the experiences of adults with intellectual and developmental disabilities and co-occurring mental health concerns, to explore their experiences of trying to find and access mental health services in Cache Valley. That was a very eye-opening experience. It was really engaging and meaningful for the participants and just shined a little bit more light on what those mental health disparities can look like, especially here in Cache Valley. I also work on training for individuals with disabilities and individuals who work with them, and also family members and caregivers, so that we are aware of what those health disparities are and try and take action to address those. So primarily that's what it looks like for me involved in my work. I will also add that personally I'm very passionate. So even outside of work, for me, I tend to find ways to be involved with promoting healthcare and health education. I am very active if in my circle of friends, if somebody mentions a health topic that they are interested in, I'm one of the first to jump into that conversation and talk about resources, so how we can find health information. And I should also add, the last thing about my work, I am part of the Utah Health Literacy Coalition, so I spend some time every couple of months working with them to find ways to increase health literacy in Utah and increase access to healthcare services. So that was a lot of information from me. But really, I spend a lot of time trying to identify health disparities and ways to address them. So I'd love to know now how health equity and intersectionality are involved in your work.
This is Trevor again. So we at the Central Utah Health Department, we will look at all of our contracts that we receive, whether they're from the state, CDC, whoever. We will look at our contracts, and Monica will work with the coordinator over them to see how we can approach diversity, equity, inclusion. So we try to really take that focus, whether it's just, hey, can we include the certain population in this emergency preparedness full exercise? Or are we making sure our flyers are in Spanish? Or are we holding an event specifically for our Pacific Islander population? So we take that just at a simple, very basic level and just look at things and say, hey, are we including everybody? And it's interesting because if you don't look at that, you really do leave out a group of people. And it's not that you don't mean to do that. It's just you keep doing keep doing things the way you do them over and over if they're working. And then you're like, oh my gosh, I didn't realize I should put this flyer in Spanish. I'm missing this whole group of people. Or I should have been doing this to include more people. And so it's really interesting if you don't take a second to make it just a priority area, you really just leave it out if it's not something you're familiar with. Like, I'm a white Mormon male, and so I know I have my bubbles and I stick to them. So I think it's great that we can bring that into our work.
Yeah, thank you. So paying attention to what's going on outside of you and, realizing that other people's experiences are different for sure.
Hi, I'd just like to add to what Trevor was saying. In our work at the Office of Health Equity, we do fund multiple partners to do this health equity work, right? And Central Youth helping one of them. And what we describe and what Trevor was describing as well is this like health equity mindset where we think about everybody without leaving anybody out, right? So it should already be embedded in the work, which I know is a newer concept, because we often don't think of that way. We always help populations by what types of grants come in, and that's kind of like the nature of grant work. But we hope that with health equity being embedded more so in grants now, that we can think of everybody, in the intersectionality, range. Thanks.
Thanks. Lane, I would love to hear how health equity and intersectionality are involved in your work.
So I work closely with our community health workers, and we do have a DEI person here at our health department currently, but with all the political stuff that's going on, I don't know if that's going to change or what. So I know when I worked in early intervention, I would have individuals that were born and they had different genetic variations and stuff. And so I just realized that there's not a lot of help and support for those individuals out there. And I formerly worked in the schools as a school counselor as well. And I've seen like a big increase in individuals identifying as LGBTQ and just needing help and resources. We're currently in Tooele County, we're trying to reach out more to our Pacific Islander populations, as well as like our Latinx community. And yeah, those are some of the things we're working on.
Awesome. Thanks, Lane. So we've got a variety of things we're working on here as a group. And I'm going to go back quickly to the official definitions. So we've talked about making sure that we're paying attention to all of the groups who are in our area and being very active about addressing that and making sure that we are making things accessible is what I'm hearing. So we are definitely making sure, or at least trying to make sure, that everybody has a fair and just opportunity to attain their highest level of health. And what we'll dive into a little bit more is intersectionality and how we had a little bit of that in our discussion just now, talking about different backgrounds and making sure populations are attended to. So we've talked about racial and ethnic groups, also LGBT groups, different minority groups, and how those interact. So we'll dive into that a little bit more. First, because I specialize in disability health disparities, I have some information that I pulled from, it's actually a report that was just published in December of last year, 2023, by the Department of Health and Human Services. I believe it's called the Utah Health Update, if I am quoting that correctly. But I have some numbers that help paint a picture as to what disability looks like in Utah and how important it is that we address health equities for people with disabilities and how impactful it is. 1 in 4 Utah adults has a disability. So officially 26.4%. We know that data is not perfect. It could be underrepresentative of the population of adults who have a disability, could be much greater than that. But based on what we collected, 1 in 4 Utah adults report having a disability. On top of that, or just to elaborate, disability healthcare costs in Utah are huge. We spend approximately $4.8 billion per year, and that's about 29% of the state's healthcare spending. So those are all expenditures related to disability and health. Trevor, yes, I see a hand raised.
Yeah, what are we classifying as a disability?
So I should have pulled the way that we collect our data, and Brett and Teresa also probably know this better than me off the top of their heads. There are different categories. So disability as a general category includes cognitive, which is actually the largest category of adults in Utah who have a disability. They identify as having a cognitive disability. I believe it's about 16% of adults. There is visual or a physical impairment or impairments to activities of daily living. So things that keep you from eating, dressing, bathing. So that it does break down into smaller categories, but there are, I think, 5 or 6 official categories. So there are a quarter of Utah's adult population, and it could be underrepresented. We have to remember that data isn't perfect. And a very large portion of our state's healthcare spending goes towards disability-related healthcare costs. We also know, based on our data collection, that adults with disabilities in Utah are more likely to experience domestic violence. There is a lot that goes into health disparities, but there are individuals who have disabilities are less likely to be believed by police or less likely to have a police response when they call for help for domestic violence. They are also at higher risk for chronic health conditions, so that includes obesity, diabetes, lung conditions. They're also more likely to experience poor health outcomes overall. They're more likely to smoke also and to be less physically active. So some of those contributors to health outcomes, those things that we know are really important, they are more likely to participate in. And based on data that we've collected, the state has collected, and also data that we've collected at the Institute for Disability Research, Policy, and Practice, we've heard that individuals with disabilities often face additional barriers when they're accessing and trying to receive healthcare services. So, and since we're talking about intersectionality today, we can think about people with disabilities who are in rural settings. An important cross-section there is individuals who do not have transportation or who have infrequent access to transportation, who need to access healthcare services. When you're in a rural location and you don't have the transportation necessary to access those healthcare services, especially if you are someone with a disability, if you live in a residential home, you rely on staffing. That just adds another layer of complexity when you're trying to access healthcare services. And as a side note, we do have a lot of conversation about telehealth and how Zoom has made it so that in some ways healthcare is more accessible. But it has not been a magic pill. It hasn't solved all of our problems because there are some health concerns that are best addressed in person. And not only that, but we still don't have equitable access to internet throughout rural areas of Utah. So there are still some areas that don't have sufficient internet sometimes. Sometimes they do have internet access, but it's not strong enough to support a Zoom call or telehealth appointment. And there are still areas that don't have affordable access to internet either. So keeping that in mind, we do have telehealth as an option, but it's not a fix-all. I know we're all tired of hearing about COVID-19, but COVID was a very important part of the last couple of years and showing just how many disparities there are. It really highlighted the disparities faced by people with disabilities, particularly because there were a lot of reasons for people with disabilities experiencing more severe cases of COVID or struggling to access healthcare services. For example, in the residential habilitation services setting, where individuals with disabilities may rely on their staff to provide transportation to a healthcare appointment, these types of services experienced severe staffing shortages. So sometimes those services just weren't available, even if it was needed. And we also know that people with intellectual and or developmental disabilities were more negatively impacted, in part because of service settings, the staffing issue. People with disabilities were also far more likely to have a severe case of COVID and to be hospitalized. Another spotlight, this was highlighted by COVID-19. It had already been kind of in the public eye or funding eye, is mental health and individuals with disabilities. Data, while again not perfect, has demonstrated pretty clearly over the last couple of years, especially that people with disabilities are more likely to experience mental health concerns than those without disabilities. So disabilities as a general group experiences mental health concerns much more frequently than those without disabilities. And when you kind of get into the nitty-gritty and look at different disability groups, those numbers look a little bit different, or the experiences can look a little bit different. The group that I work with specifically here is individuals with intellectual and developmental disabilities. For a long time, there was a myth, and is still sometimes found around in our communities, that individuals with IDD or intellectual and developmental disabilities couldn't experience mental health concerns, or they didn't experience mental health concerns. And so that was something that just wasn't addressed or wasn't considered as a possible health concern. That myth has been better addressed recently. We know that individuals with intellectual and developmental disabilities can and do experience mental health concerns. There are resources becoming available that are very helpful in addressing those and identifying mental health concerns, because sometimes that presentation is different among individuals with intellectual and developmental disabilities. And on top of that, I mentioned my project earlier last year. We know that individuals with disabilities face additional barriers to receiving effective mental health care. Part of that is due to some myths. Like I mentioned previously, there was also a myth for a while that is still sometimes found among providers, that individuals with disabilities can't benefit from therapy or can't participate, which we know is also false. And there are some awesome resources that have become available recently to help mental health practitioners adapt their services and make sure they're accessible. I've talked a lot about disability. I do want to address an important disparity that we see among racial and ethnic groups. The prevalence of serious mental illness is highest for individuals reporting 2 or more races. So we know that it's a group that needs competent, effective mental health services. And interestingly, but not surprisingly, individuals who are African American, Hispanic, Asian, and or American Indian Alaska Native often experience overdiagnosis of schizophrenia. So a diagnosis of schizophrenia when it's incorrect. They are also often prescribed higher doses of antipsychotic medications when it is not appropriate. and they're more likely to be involuntarily hospitalized when they are seeking care. So there's a disparity in the treatment of individuals from these groups when they are trying to access healthcare services, mental health care specifically. So another nod to intersectionality here is to imagine that you are an individual with a disability who's also from a racial or ethnic background that is not the predominant white. And imagine yourself in that scenario trying to access mental health services. Okay, we'll talk a little bit more about specific disparities and then we'll get back to some discussion. As I'm going through these pieces of data, if you guys have any comments or anything you'd like to share, feel free to pop it in the chat or unmute. This is from the Utah Health Update Report I mentioned previously in December, that was published in December of last year. These are disparity ratios. The yellow dotted line that you see on that graph is at 1.0. If any level is there, it means it's equal to the overall Utah population. So this is the graph for white non-Hispanic populations. And what this is telling us is that white non-Hispanic individuals in Utah don't have a health disparity when it's related to accessing medical checkups or coronary heart disease deaths. That means those rates are equal to the population of Utah. But they do have a little bit more arthritis. That's that 1.1. Because it is greater than 1, there is a disparity there. However, on the other side, where values are less than 1, that is where the disparity does not exist. That means this population has rates that are lower than the overall population of Utah. So individuals who are white and non-Hispanic are less likely to experience child poverty, less likely to have tuberculosis, and births to adolescence are less likely to occur in this population compared to Utah overall. In Utah, racial and ethnic populations other than the predominant white are at greater risk of poor health outcomes compared to Utah overall, and also particularly compared to white non-Hispanic individuals. So each of our major categories that we collect data on in Utah for racial and ethnic groups are presented in the next couple of slides. This shows some of the highest and lowest disparity ratios. So it will show where the health disparities are some of the worst, and then also some strong points in those communities where there is not a health disparity, where they're actually doing better than the overall Utah population. This is the graph for American Indian and Alaska Native populations. You'll see that stands out here is child poverty, motor vehicle crash deaths, and poverty in general. There are some strengths though in that infant mortality is lower than the Utah overall population, as well as breast cancer deaths and prostate cancer incidents. For Asian and Asian American populations, the tuberculosis incidence is much, much higher. So the disparity rate there is very high compared to Utah overall. But asthma and breast cancer deaths are much lower. And for Black or African American populations, tuberculosis is also high, as well as gonorrhea, child poverty, and poverty overall. There are a little bit lower suicide rates than Utah overall, as well as mammograms are actually completed more frequently as a preventive healthcare measure. And for Hispanic and Latino populations, poverty is up there. They also experience greater numbers of births to adolescent parents. They're also more likely not to have health insurance coverage and more likely to have fair or poor health compared to Utah overall. And for Native Hawaiian and Pacific Islander populations, chlamydia incidence is higher. That disparity ratio is 3.3. Diabetes deaths is also over 3. And we have poverty as well. There's also a slight increase in overweight or obesity. So that was a lot of health disparity information in a condensed form very quickly. But I would love to hear if any of you are surprised by any of those numbers, if you see those kind of in action in your work, if you think it's a pretty accurate representation. Trevor's nodding.
I was gonna say I'm surprised about the tuberculosis incidence, and I believe it was Asian and African Americans. Like it was just like with all the other graphs, it was like 2, 3, maybe like up to 5, and then all of a sudden it's like 10. Like it's such a big, major disparity. And I was just like wondering if you know more information about like what specific, if there were any specific factors that related to the tuberculosis incidence.
I actually haven't explored that myself. If Breck or Teresa, if you guys have any comments, please share. But that's something that I would have to learn more about, is those factors that may be contributing, at least here in Utah.
Yeah, I'm also unsure on that too, but we can reach out to our data folks as well, as they might have more insight.
For me, those graphs are one of the eye-opening things that really help illustrate where those disparities are. Obviously, it helps give a visual representation of here is Utah's average with the yellow dotted line, and then displays how severe those health disparities are. You know, what is that disparity ratio and how does it compare to Utah overall? So for me, that visual is very helpful. Lane in the chat said it's hard to say he's seen similar things, but the poverty makes sense. I'd like to move on to the next step, which is to address intersectionality in our work. One of the examples that I often think about because of my public health background and because COVID was so recent was that non-Hispanic, Black, and Hispanic individuals with disabilities, so there's our intersectionality, there's a racial or ethnic background and disability status, were more likely to be hospitalized for COVID-19. In some of my works, I've done some work with rural counties. I also have personally family members and friends who are resistant to the concept of intersectionality, and also health equity on top of that. But they tend to believe that intersectionality doesn't exist, or that it's made out to be something that it's not. There are a couple ways that I address this in friends and family, but also professionally. I would like to hear how you guys address this as well. What I'm going to do is move into my favorite visual representation. So we had some graphs that showed disability ratios. Those are a little bit harder to understand though. You have to understand some elements of data and be able to read a graph. This kind of representation visually, I think, is very helpful for me to think through when I'm trying to conceptualize a case. If we have somebody looking for disability services and I'm trying to think of the best way to help them, I prefer this Venn diagram, you could call it, of different identities and how they intersect and how that looks different. Do you guys use any tools like this when you're working with groups who are hesitant about intersectionality, or who haven't had meaningful discussions about what it means other than political exposure?
I'm sorry, can you rephrase that again?
Yes.
Or restate it?
So I am wondering if any of you have used visual representations like this when you're working with groups who are maybe resistant to the idea of intersectionality, or who are having trouble just kind of grasping what it really means.
I know that when Monica has presented to our Board of Health that she's used some visual representation of data. But I think also like as new graphs and new visuals come out, I think it's helpful to be able to have those and share them because there's a lot of different, I mean, health equity within our health department's fairly new. And so I don't know, I'm kind of interested to see what other health departments are using to demonstrate this.
I was just going to add that, as a state agency in the political climate that we're in, we have not been allowed to talk about this as much, but we did used to have trainings that talked about this particular, intersectionality topic. And I think they've looked similar to this, but there's been diagrams that kind of cross over, or what I don't know what they're called, but one of those like grids that has there are two different sides, and then you can like cross over, and sometimes they link, like you have multiple things linked together. So, but yeah, I don't know what they're called.
Awesome. So it sounds like you guys have used some visual representations. I want to share another one that I found that I really like. So this one is another visual representation, but it's interactive. So you start at the top and then you scroll down and it adds more information and provides a visual explanation as you go through. It talks about access, inclusion, participation, and recognition. And you just keep scrolling and it brings up points to consider and why intersectionality is important. And as you go on, it provides kind of that layering effect similar to the Venn diagram approach that just illustrates how things can become more complicated when different backgrounds or identities intersect. So this is one of my new favorites because it provides a really good visual representation that is easily accessible. You could share a link with somebody and they can just scroll through at their own pace and learn. And there's this final visual representation that has different layers that shows you how it can become more complicated. And I see Wayne shared one in the chat, the gingerbread person. Awesome. Thanks for sharing. I also should have included an update on what's happening legislatively when it comes to talking about diversity, equity, and inclusion. There's some interesting political atmosphere around it right now that will possibly affect what we're doing. Let's see, Mindy shared. Oh, you put the link in the chat. Okay. Has anybody, I wish, I should have looked this morning to see where that's at. But it sounds like Breck and Teresa, any potential legislation might affect what you're able to do in your office. Is anybody else worried about how legislation surrounding DEI might affect your work and ability to implement?
I mean, I can briefly share. I believe that the House Bill 261, I think it was like equal opportunity bill, specifically around DEI, did pass. And so we're kind of holding on and waiting to see what comes of it because it will affect our work, including using general terms like health equity. And so especially at the state level, we're very cautious about how we're going to talk about health equity and trying to find new or different ways to discuss it and still be able to do the work, especially as, we're all, USU and some of the local health departments are our partners. We really want to still be able to do the work and be able to support and provide technical assistance as much as we can. But yeah, we are yet to see how this will affect us. And we're all just a little on our toes about it.
Thanks for sharing.
With Central Utah as Monica's supervisor, we've reassured our team that health equity will still be a large focus. Within our health department, we may not call it health equity, we may call it, like outreach coordinator, a resource officer, whatever it may be. But I feel like we've done a really good job with our Board of Health of not, when we first started, there were some hard conversations because they thought it was political at the beginning. And so we've done a really good job at just saying, hey, this is a vulnerable population. This is the population that is being left out, that doesn't have a resource. And they actually do see some of these populations that they see like needing help. So for example, we have a large influx of Peruvian immigrants that come and work on our turkey plants, our egg farms, some places like that. And so they see that that is a burden in our community because they're not receiving any resources. And so it's been nice that we've approached that way and not like, hey, health equity, diversity, inclusion, like we've had to approach it with these farmers and cowboys a little bit different. And I feel like that's actually set us up for success. I mean, things will look different. We'll have to adjust, but it's not something that we're going to drop at all. We are going to make sure that this is still a focus. And even when we've talked about it with some of our staff, they're like, what? That's so weird. Why would we not include that? So I don't know, like people are worried and it is frustrating, but we have every confidence that like everything's going to be fine. We're going to still do that work because it just can't stop because of a bit like that. So, oh, community health. Okay, cool. Thanks for sharing that lane.
Okay, awesome. Thanks, Trevor. So that's got me thinking a little bit about something that we have done when we're discussing health equity and intersectionality, moving away from those more politicized terms and instead really focusing on the values that our communities appreciate that are behind those terms. So what you had said, approaching it a little bit differently with cowboys is we've had conversations with rural groups about community and the value of supporting others and just forming and building a strong community and how important it is to make sure that we're including everyone in the community. That really resonates with people. It's really resonated with the groups that we work with. So even though we won't be able to use the official language because it's become politicized, we can definitely work at getting to the values that are behind that the people in our communities can relate to and help that going.
If I may also share, I was telling Monica that some of this, I do feel like it really does come out of fear and a lack of understanding. I did work at a university setting and before the health department, and there were many times where those topics were very much involved with policy and politics, or so I can see where there might be frustration why some people have proposed this bill. And it's like we've talked to Monica, it's like we have to help people understand the work we do and why we do it. And that it is really, there is a need for this and that it's not attached to anything else. Is we really want our communities to be whole. And I think any county commissioner, mayor, governor, whatever, they want their community to be a community. They don't want to leave anybody out. So
Thanks, Trevor. We've got 10 minutes left. I wanted to end on a few recommended readings. It sounds like most of us here are from public health backgrounds or currently work in public health, so you may be familiar with these books already. I have these on my shelf in my office because I loved them enough to keep them, and I keep telling myself I'm going to reread them, and they're just waiting, collecting dust on my bookshelf, but they are incredible. I have lots of little sticky notes throughout them. If you look at my copies, there's a lot of information about health disparities in general and how our healthcare system reinforces those and ways that we can make a difference as individuals. So this first one, The American Healthcare Paradox, Why Spending More is Getting Us Less. That one focuses a lot on spending, obviously, and how the way our system is currently orchestrated contributes to less effective spending than other countries. So if you're interested in systems and what that looks like here compared to other places, that's a really good read. And The Healing of America is the story of an individual who was traveling, seeking healthcare, and shares his experiences in different countries and different healthcare systems. They're really, really good perspective providers, and I would highly recommend that you read them. They aren't terribly long and they're a fairly easy read. They're not like textbooks. So if you really want to learn more, I'd recommend that. You can borrow my copy if you want, because it's just sitting on my shelf with all my sticky notes in it. As we have talked today, I've had a lot of thoughts about addressing health equity and intersectionality, and especially getting at the values that are behind those and connecting with communities rather than struggling with the inflammatory response that happens sometimes because they're political terms. Thank you all for participating. I really appreciate that you attended and contributed. We can take some time for a few questions, or if there's anything else that we would like to discuss today, if there's something you want input on, or if your team has an idea that you're considering, and anything along those lines. We've got a little bit of time left.
I'll speak just a little bit more. I saw in the news recently that there was something about like public restrooms versus in-school bathrooms and individuals identifying as like trans or opposite genders being allowed to use those bathrooms and stuff. So currently, I think they said they're not approving it in the schools, but like in the public, they will. Aren't they just, or don't you think it'd be best to just look at like the design of those buildings and make more like family type restrooms, or like where an individual person can go in and lock it? I don't know. That's just my thoughts.
I am a proponent of universal design because in the world of disability, universal design is the most accessible way for individuals and everyone across the board to be able to access the services that they need. And I would say that restroom access is absolutely included in that. And as far as universal design goes, it would be the most accessible versions of restrooms. And personally, I love to have my own saw that locks. So I am a big fan of that approach, looking at our building designs and how to make them, first of all, more accessible, and second, the safest setup for everyone.
Perfect. Yeah, I knew there was a term for it. I couldn't remember universal design. And I know that usually costs like more money and stuff, but like after working in the schools with individuals that are seriously struggling with that issue, and then realizing that like just having to go to the bathroom like makes them feel uncomfortable, and they have to often go to a secretary and get a key for a separate bathroom, and it's just like one extra step, and I just saw it affect their mental health really bad. And anyways, that's just something that I'm excited to see more stuff move in that direction, because I think it'll help a lot of individuals out. So
For sure. Thanks, Lane. And I also skipped ahead to my contact slide here. My email's there. If you have any questions, if you're interested in collaborating at some point, I am always down to work on a grant, anything related to health disparities, health outcomes, disability.
Okay,
you think you
awesome.
could share your slides? Oh, sorry.
I can definitely share the slides.
Yeah. I was just gonna say thank you so much, Rachel, for the presentation, and thank you so much to everyone who came. The recording will be shared. Rachel, if you'd like, you could send the slides, or you can send them to me, and I can make sure that's sent to everyone that registered for this meeting. So, but yeah, thank you so much for coming, and have a nice rest of your day.
Thank you.
Thanks
I
so
really
much,
did.
everybody. And thanks, Rachel. That was a wonderful presentation.